Good evening and wishing you a safe and peaceful holiday. My name is Damone Chaplin and I am the Health Director for the City of New Bedford Health Department. I am joined here today with a distinguished panel of subject matter experts and community partners to celebrate Men's Health Awareness Month and our first Prostate Cancer Awareness Week in New Bedford, as designated by our mayor, John Mitchell, last year during our first annual Prostate Cancer Awareness Conference. As many of you may know already, prostate cancer, like COVID-19, is having a disproportionate impact on our communities of color, particularly our men of color. And today we are here to discuss strategies to reduce stigma, raise awareness, and save lives, hopefully. In the United States, prostate cancer is the most common and second most lethal major cancer in males. Men of African descent, including our Hispanic men, are 1.5 times more likely to be diagnosed and 2.5 more times likely to die from prostate cancer. But with early detection and screening, nearly all men are alive in 5 years. Hence the name of our Prostate Cancer Awareness Initiative in New Bedford, Be Alive in 5. So tonight I'd like to introduce you to our panel of experts. We have with us today Dr. Patricia Andrade. Dr. Andrade is a native of New Bedford and chief of surgery at Morton Hospital with a special interest in breast surgery. She has been a physician in the South Coast area for over 25 years and is also an avid supporter of the YWCA, and she is my chairwoman of the New Bedford Board of Health. So Dr. Andrade, welcome and good evening.
Thank you. Welcome. Welcome to everyone else. Thank you for asking me to participate. This is an important initiative for many reasons. Prostate cancer awareness and screening cancer awareness for prostate and for men is a hugely underrepresented topic. And it's important to dedicate time and dedicate expertise to make sure that men understand that this is an easy screening. This is something, and screening is preventative. And if you screen early, you can avoid large major surgery or radiation, and or also the subtle effects, ultimate effects of metastatic disease. And it's a simple blood test that should be done yearly with with a regular exam with your primary care doctor. And again, like Damone was saying, we've certainly seen a demonstration of the serious disparities that happen because of racial problems in this country, and it's really been accelerated with the COVID pandemic. But we also see this not just with the COVID, but it exists this huge disparity in terms of timely diagnosis, appropriate treatments with prostate cancer, with breast cancer, with multiple other cancers that affect all of us. And so, Damone and I have talked about racial inequities and racial problems, it being a public health problem, and we are really have some plans and thoughts to address that, because it ends up being a significant domino effect. When you have racial bias, you young people in high school are not encouraged to go on to college. They're not encouraged to go into medical fields. They're not encouraged to go into fields where they can make a difference. And so the whole domino effect of this racial bias and racial inequities end up with a serious lack of diversity in the healthcare system, in our own communities. And that lack of diversity, that lack of racial equity presents as, from a patient's perspective, distrust, which is inherent in them seeking the care that they need. But on the other side, on the physician side, you have again racial bias, and you have not being understanding people that are not like you, and not giving the respect and the treatment that are needed. And so there are all of these parameters of racial inequity that affect healthcare. It affects the daily healthcare. It affects the preventative healthcare of specifically of people of color, because again, when you don't have an equitable system in the healthcare, you don't have equitable representation, people won't really want to partake in the system, and they won't be necessarily thought of in the same way as other patients. And so it is an important conversation to add in to the basic tenets of healthcare, preventative treatment, but the whole concept of racial bias, racial inequity, really has to be part of this conversation, because we see it happening all the time and it's a reality. And if we don't address it, then you know we'll just end up where patients are not treated fairly, physicians don't understand all of the patient population, and these disparities just continue to broaden. And so it is an important. I mean, the prostate is one part of this whole discussion, but it's important to dedicate time to make people aware, because I think there's minimal awareness about prostate. We were just saying we need advocates to really bring this to the forefront, so that there's no ground loss on the progress that's already been made, but more progress can be made in the future. So that's
Thank you, Dr. Andre. You've hit on a bunch of the key issues that we've talked about in private, and I will soon be talking about in public, about challenging the stigma around physicians in the field, and also some of the concerns that translates into physician and patient care. So thank you for those comments.
You're welcome.
Yep. Next, I'd like to introduce Dr. Guy Fish. Dr. Fish is the CEO of Solanix. Am I saying that correct? Solanix?
That's good. Yes.
Diagnostics, a company combining artificial intelligence and live cancer cell culturing to predict when a patient's cancer is aggressive and when it is not. Prior to Solanix, he has held leadership positions at Flesher Spate Incorporated and Flesher Spate Ventures in the Division of Funds Management. So this evening, I'd like to introduce you to Dr. Guy Fish. Dr. Fish?
Thank you, Mr. Kaplan. Pleasure to be here tonight. Pleasure to address all of you with regard to prostate cancer. Thank you, Dr. Andrade, for putting into context what happens in medicine. It's not a simple thing of, I have a symptom, get a diagnosis, I get a prescription, and I'm all better. There are lots of things that get in the way in terms of when do you present? Why do you present? Who do you present to? Are they listening carefully? Do they hear you? What is the steps? What are the steps in getting to the right diagnosis? Is it the right diagnosis? What are your options? And with the options, what are your choices with those options? And how do you continue to have a conversation to follow up? So that complex landscape that you laid out, where there are so many areas for bias to creep in, is exactly the problem that Black men, brown men are having in this country regarding to prostate cancer. My comments tonight, I'd like to deliver three messages in particular. The first message is that prostate cancer particularly devastates the African American and brown community, and it affects all of us. That's not just the men, it affects all of us. Number two is that African American communities and brown communities are not really doing the job of addressing prostate cancer. We need to get involved in doing the work and understanding what the options are. And then the third thing is that there are some new tools that we need to understand and take advantage of to be able to change our experience with prostate cancer communities. So if I could see all your faces, or if we were live, I would do the following. I would ask how many people here have had an experience with a loved one or a friend with prostate cancer, and I'd ask you to put your hand up. And my hand would be up too, because it was my dad. Dr. Kennedy has his hand up. So my dad was John Fish. He was a chemist. His father, Frederick Fish, was a schoolmaster. My mother, Juanita, is a nurse, and her mother, Martha, was a domestic. And I grew up in Cleveland with 3 sisters, one of whom I was very competitive with. And when my sister Deborah decided to go to an exclusive women's college, I had to play my trump card. It was applying to Harvard. And God is good. I got in. Harvard was not easy. As W.B. Du Bois says, he was at Harvard, but not of Harvard. And I know what he's talking about. But again, God is good. And after finishing Harvard with a science degree, I attended Yale School of Medicine. And it was there that I got the call that none of us are prepared for. I remember moving into a new apartment. It was my own apartment for once. And I was pretty happy studying medicine. And despite studying medicine and disease and even cancer, I can still remember getting that call from my dad. And he was telling me that he had been to the doctor and he had found out that he had prostate cancer. So I know personally how hard it can be hearing that. You get fear, doubt, betrayal, sadness, compassion. And the entire family goes through that. It's not just you or my father, the entire family goes through that. So for me, it was a story of good news, because after finding out about it early, my mother and me, being both plugged into medicine, we took full advantage of all that was possible. And Dad lived 15 more years. Got to see the birth of 6 grandkids and got to know them until he went home. So that is one story. And I hope that all of us get to have a story like that, where we can intervene early and have the fruits of the years that God intended for us. But let's step back a second. Let's answer a few things first of all. First, what is the prostate? Well, it's a small gland that only men have. It's part of the sexual reproductive system. The gland lies under the bladder and in front of the rectum. And its job is to provide fluids and lubrication and nutrients for sperm as they usher forth. So what's prostate cancer? Well, cancer occurs when the controls on the regenerative properties of cells are undone by some means. This means that instead of cells having a natural, normal lifespan, they instead start acting as if they're immortal. And our body has natural defenses against this. In fact, we're all getting cancer all the time, but 99.999% of the time, our body handles it. Occasionally, controls on these tumors are lost and they grow into something more serious as a health problem called cancer. So prostate cancer occurs when some cells in the prostate gland lose their controls and start acting immortal. Any man who lives long enough will actually almost be guaranteed to develop prostate cancer. And since we all have fathers or are fathers or have brothers, it affects all of us. So that was number one, that prostate cancer does affect all of us. The statement number two that I made is that the effect can be devastating, and that we as an African American community have not been addressing it. What do I mean by that? So I'm going to share a few slides. So the problem we've been talking about is cancer, period. The number one cause of death for Black men, like on this chart for men overall, it says cardiovascular. That means heart disease, particularly after you're 45 years old. Anybody know what the number one cause of death is for men between 0 and 45 years? It's actually gun violence. That's another lecture. We need to get busy and address that too. But the number one cause of death for over 45 is cancer. Is cardiovascular disease. The number two cause of death is cancer. And if you look at the breakout of cancer for men versus women, the men bubble at the top there, you can see about half of the cancers that men die from are prostate cancer. Another quarter or more is lung cancer, and the last bit, about a quarter, is colon cancer. Women have a different breakout. Women, it's breast cancer that is number one for them, followed by lung and colon. So we need to know these statistics. We need to know this every time we go into the doctor's office. How's my heart? And what's my risk of cancer for men of the prostate, the lung, and the colon? You need to know this. You need to know that going into the doctor's office and advocating for the right kind of checkup. When men get cancer, 1 in 8 men will get prostate cancer. 1 in 40 men will die from it, which means that, overall, it's not that aggressive of a tumor, but when it is aggressive, you need to do something about it. Well, the other statistic here is that the odds for African-American men dying from it, as Damone was saying, we are 2.5 times more likely to die from it. And why is that? Largely it's because we need access to screening. It's a big contributor to this problem. And on top of that, the adequacy of the screening that we have has been thrown into huge disarray. We don't have the best tests, but even so that they're not the best tests in the world, we need to rely on them to have the conversation with our doctors about how am I doing with my prostate. We need to have shared clinical decision making. When you get to diagnosing your prostate cancer early, it turns out that the survival rate over 5 years is 98%. Those men survive. When you get to late diagnosis, only 28% of those men are alive at 5 years because the cancer has already spread to your bones and to other distant organs. So clearly, like my dad, if you could live for more years, 15 more years in his example, you would want to do that. But Black men are dying like flies because we are not doing the right thing. We're not getting to the screening and we're not having the conversations. So what is the screening process? What we're talking about is a continuum of screening, diagnosing, and then treating the problem. We want to screen early. We want to know when to do it, how to do it, and what to do with the results. When to do it. In general, men need to screen between age 50 and 75, unless you're at higher risk, which means at age 40. Higher risk means if you have a family history of prostate cancer in your brother or your father. Higher risk also means being Latino or African American. So for all of us on this call who are listed, who are either Black or brown men or have a father, brother that is African American or Latino, they are by definition at high risk and need to start their prostate cancer screening at age 40. So how do you do it? You see your doctor and you discuss having a PSA test. Now, I mentioned the PSA test as something which has a storied history and a lot of problems around it. It's not a perfect test, but you need to do it. You need to have a test, no sex and no vigorous exercise a week leading up to your test. You go in, you have a blood test. Maybe you have a rectal examination to examine for nodules. Those are all you need to do to screen. The problem is that over the years, starting in 2012, the U.S. Preventative Task Force put out a recommendation saying, we're not sure how much good the prostate specific antigen test, PSA, is doing. We think maybe we should stop doing it because we're maybe overdiagnosing people. And that's what happened. They stopped doing the test. And then 5 years later, we started seeing late stage men presenting who were not screened early enough. And now they're metastatic disease and they're dying. So in 2018, they began to walk away from that recommendation of not doing PSA testing. You need to do the PSA testing. You need to advocate for yourself that you need to have this. Now, here's some good news. Most men who get screened will have a negative PSA test. But if you have a positive test, you need to go on to more testing to confirm that there is prostate cancer there of a serious enough degree. The work that I personally have been doing in my company, Selenex, has been getting around the issue of telling apart aggressive disease from indolent disease. And there have been journal articles about this coming out consistently saying prostate cancer, we need to do something to distinguish aggressive from indolent disease. And the company that I have been working on has been doing that, looking at how we can tell the men who have their tests come back which ones are really sheep and wolf's clothing and which ones are actually the wolves. The final area here is that you really do need to be an advocate for your own prostate cancer health. You need to be able to go to your doctor and say, I know that I'm at high risk. I am 40 years or older, and I am African American or Latino, and I want to have a PSA test. I know there's been some controversy, but I need to have this test to understand what my risk is. You need to really, be very firm about that. And then once that test is in, you need to think about the biopsy. You need to have a conversation with your doctor about that result and whether or not you need to have a biopsy to further tell you whether you should go to surgery or not, or to radiation or whatnot. So to wrap it up, the three things that I tried to get home today are, number one, prostate cancer is serious and affects the African American community in particular. It affects all of us, men, women, because we all have brothers and fathers. Number two, if unaddressed, it has consequences, and we have not been addressing it. And number three, there are tests, the PSA test, and other tools to change our experience of prostate cancer so we can get ahead of this and have those conversations to reduce the rate of death from 2.5 times more than the general population with prostate cancer to our fair share of deaths and our fair share of life. I'll stop there.
Thank you, Dr. Fish. That's a perfect segue into our next panelist, Dr. Caldas. Dr. Caldas is a New Bedford native and graduate of University of New England College of Osteopathic Medicine. He has provided primary care services to the greater New Bedford community for greater than 23 years and recently held the position of Chief Medical Officer for South Coast Hospital Group from 2011 to 2019. Dr. Caldas has now resumed a full-time family practice at Hawthorne Medical in Dartmouth and is a close friend and partner with us in our fight against opioids here in New Bedford. And Dr. Caldas, I think this is a great opportunity to follow up on Dr. Fish's comments around what questions should a patient, how should a patient engage with the family physician or the primary care physician around prostate cancer?
I think they should really engage directly during their office visit. And one of the problems we've spoken about is really getting people to feel empowered to come forward and ask those questions and to understand what questions to ask. So many people come in to an office visit and they're really waiting for the doctor to tell them what's going to happen. And so there are two parts, patient and physician in this equation. The physicians need to be educated and need to understand the increased risk of, the Black community and Hispanics, and understand that they should start screening earlier. Because I think most people are just following the general recommendations around 50 years old and not understanding that screening should take place sooner. We understand that about breast cancer, and we, frequently will ask about the age of onset for breast cancer and start screening earlier. But we aren't at that point, I don't think, with prostate cancer screening. Trying to get someone to come in and get the test is a great thing. Some of the restrictions that we spoke about, the no sexual activity and vigorous exercise, make it a little bit more difficult because once someone leaves the office, the likelihood of coming back, decreases greatly. So frequently we're catching people, in the heat of the moment, getting the exam done, getting the digital rectal exam done, and then having the blood work done, as soon as we can. I have that conversation frequently with my patients, and those patients of color have that conversation more pointedly. Despite the USPSTF, the task force casting shadows on the digital rectal exam, and the PSA have continued to do those exams for men, and explaining the necessity of doing them and the importance of getting that done on a regular basis.
Thank you, Dr. Caldas. I had a similar experience. I ended up changing physicians, as you may very well know, because I didn't feel as though I was getting the type of attention I needed around things that were specific to me and my specific age range now. And so it's really important to advocate for yourself. Part of the whole point of this prostate cancer awareness is for men to be able to advocate for themselves. That's how we got to this point about prostate cancer awareness. It's self-advocacy. We want you to know your risk. We want you to know your options. And more importantly, we want you to know your numbers. And so those three things in themselves are going to go a long way in helping men, move forward with understanding their risk level as it relates to prostate cancer. So thank you, Dr. Caldas.
I did have one more comment.
Yep.
We do have had some advances with MRI, which can help to try to distinguish some of the wolves from the sheep and wolves clothing, and really waiting for more laboratory testing that may help us to stratify people before they get to the urologist, so that they can understand their risk before they get there.
And thank you again for your comments. Our last but not least, our presentation, Mr. Mark Kennedy. How are you doing, Mark?
Well, sir, how are you?
Mark is the Senior Program Manager in the Chronic Disease Prevention and Control Division of the Boston Public Health Commission and leads the Pink and Black Education and Support Network, a program that engages female breast cancer survivors. Mark received his executive MBA from Northeastern University and teaches graduate and undergraduate courses at Regis and Emerson College. He also has a wide knowledge about a bunch of different types of cancer, and I'll let him give the full Monty on his pedigree. Mark?
Okay, well, I'm not overly concerned about the pedigree, but I do want to point out one thing. With tremendous respect to Dr. Andre, Dr. Fish, and Dr. Caldas, I am glad to be the only non-physician on this panel, because I think that there are some things that need to be said and done, if you will, from the standpoint of engaging physicians, particularly in the context of everything that's been talked about. And that's the role that I want to play here. So as Damone mentioned, I'm at the Boston Public Health Commission. I have the distinction and the pleasure of leading the commission into the creation and implementation of its first comprehensive cancer early detection program. And there are a number of different elements to that I'll get into in a second. But let me back up and highlight some of the things that Damone and Dr. Fish mentioned in their comments, particularly about the burden of prostate cancer. When you think about some of the numbers that were shared, okay, the fact that African American men are disproportionately impacted, not only in terms of incidence, but mortality as well, clearly is bad enough. But this is not just a disease for men of color. This is, in fact, one of the most pervasive cancers. This is the second leading, most frequently diagnosed cancer, and we're talking about a gender-specific cancer. So for the cancers that burden men, this is the second most frequently diagnosed cancer among men, and behind lung cancer, the second most frequent cause of death from cancer in men. This is a big deal for men. That's why I want to make the following statement, particularly when you think about some of the comments that were made about the PSA test. Prostate cancer, to have that level of burden in the male population, is clearly, and I think far and away, one of the most poorly managed cancers across the entire cancer landscape, whether you're talking about major cancers or cancer overall. We can do better, and we need to. We need to take responsibility for our own health. And again, as I talk to my physicians on this call, I want to talk with you about provider engagement as a part of the work that we're doing in Boston. We talk a lot about death from cancer and the efficacy, if you will, around prostate cancer screening typically is talked about in the context of does it prevent death? I think that the PSA test, for most of its history, has been miscast. Prostate cancer screening, the PSA test, was never intended to diagnose prostate cancer. It's intended to let a doctor know that next steps need to be taken. And of course, Dr. Fish alluded to that. So if we talk about prostate cancer from a diagnostic perspective, it gets a bad rap. It's a screening test. And I think that if we use it more strategically, again, I understand the debate about overdiagnosis versus overtreatment. But I think if prostate cancer screening is used correctly, I think not only do we mitigate the issues around overtreatment, but we actually can right size, if you will, the use of PSA testing in a way that makes the most sense for everybody. What I mean by that is our interest at the Boston Public Health Commission isn't about looking at the endpoint of reduction in mortality. It's about looking at a reduction in late stage diagnosis. It's a very different piece. This is why we're talking about screening. This is why we're talking about early detection. And you heard Dr. Fish allude to this earlier. When prostate cancer is caught early, the survival rate is north of 98, 99%. Catching it early is the key. When you think about, again, what Dr. Caldas alluded to, which was the recommendations from the United States Preventive Services Task Force, if we're beginning screening at ages 50 or 55, we know that the statistics tell us that African American men are diagnosed younger and with more aggressive disease. We're already set up for failure if that's the case. We also know that the research that the task force used to base its recommendation on was woefully inadequate in its accrual of high-risk men, i.e. men of color. So we know that those guidelines don't really apply to men of color anyway. So I implore not only my physician colleagues on this call, but others in general, to think about particularly, and I wish that Cheryl Bartlett was here, when you look at patient populations, particularly on a community health center level, because for people of color, that's typically the first point of care. We then get up to the hospital or specialty level when it requires that. But most of us have our primary care, first point of clinical care at a community health center. Okay, so we're interested in ways that doctors can look at risk-based early detection of cancer in a standardized way across the board. And when you look at the dynamics, particularly in patient populations and the percentage of patients in a health center's patient population that are at high risk. And if you're not adjusting your clinical care to fit the profile of the patients that you're serving, then what are we talking about? Okay, we need to be talking about risk-based early detection across the board, and in particular, again, with prostate cancer, because again, if you're serving high percentages of patients that are African-American men or men of Latino descent, that we know statistically are diagnosed with prostate cancer younger and with more aggressive disease, even at that point, we're going to continue to see higher levels of mortality. So again, that's why we're interested in moving that endpoint from looking at mortality to look at mitigating late-stage diagnosis. We know that catching it early is the key. Okay, I have the pleasure of working with a gentleman by the name of Andrew Vickers at Memorial Sloan Kettering, who's done a lot of research around PSA testing, and a lot of the things that I look to as I look about the proper use of PSA comes from his work. And one of the things that he says often and loudly is that baseline PSA PSA testing changes the game, because at the end of the day, if any man, whether he's black or not, gets a PSA test before he turns 50, when you look at the PSA level at that age, what Dr. Vickers basically says is that PSA testing or baseline PSA testing is a better predictor of long-term outcomes than either age or race. We talk about the big three risk factors: age, race, and family history. I submit, given what I'm talking about here, that not getting a baseline test is also, let me repeat, not getting a baseline test, particularly if you are in the high risk category, is an additional risk factor. And I think we need to think about that from the standpoint, again, from a clinical perspective. How are we treating our patient population that we know is a high percentage and a high majority of men of color? Okay, so we're interested, again, in risk-based cancer early detection. We're interested in tailored precision, and I'll call this, again, the new buzzwords now that people like to use, precision prevention. As I talk to each one of my specific patients, who I'm seeing individually anyway, I need to understand more about that patient's family history. I need to understand more about other things that might be impacting that patient's health. But if it's a black man, especially a black man with a family history, or basically any man, black or otherwise, let's do a baseline PSA test before you turn 50. Let's look at the results of those. And then we can determine, okay, your results are low enough so that maybe I'll wait until you're 50, I'll screen you again. If the results are low then, maybe I'll wait another 5 or 10 years before I screen you again. But if the results are at or above a certain level, I can now begin to say, okay, you in particular, I need to monitor more closely. So we're setting our screening intervals based on a baseline PSA test at a young enough age to make sure that we can save more men that are at high risk and prevent them from getting diagnosed with late-stage disease. Okay, so the keys for us are risk-based early detection, tailored to the individual, and taking a prevention approach. Now, there are 3 pieces to the work that we're trying to do in the city of Boston. One of them is community engagement. That's the public-facing messaging that we're talking about. Okay, I think that we want to be taking some of the medicalese out of that language, right? We want to stop putting statistics in front of people. I think when you look at the way that Dr. Fish presented tonight, he basically told a lot of men what a lot of men, at least that I encountered, don't know. Well, first of all, what is the prostate? What does it do? Why do I care about this? But in terms of social beings, we want to be able to enjoy intimacy. We don't want to be sitting at the bar at the seat next to the men's room because we need to run in there 5 or 10 minutes, every 5 or 10 minutes. We want to have a quality of life. If we take care of our prostate, we can do that, particularly when you get to the age where this is of concern to you anyway. You want to be able to have those things available to you in your life to have a good quality of life, right? So we want a message to the public in a very different way that takes more of a lifestyle approach. It takes more of a, we need to get men talking to the doctors early, not just when their prostate cancer screening is, but when they're young athletes, to help them understand this is what it means to be a man. And as a man, your prostate is going to change as you get older as a matter of course, because that's just the way your body works. So by the time we get to talking to men about prostate cancer, we're scaring them with prostate cancer when we should have been talking to them for maybe 5, 10, 15, 20 years earlier about the function of the prostate, the care of the prostate, what it means to you as a man, so that we're not starting the conversation, we're not starting the learning curve about prostate with a conversation about prostate cancer. Because frankly speaking, that will scare anybody. And we just need to do a better job at that. From a provider perspective, again, we all know that the task force makes recommendations, and they're just that. They're recommendations. There's a lot of data out there. There's a state agency called the Massachusetts Mass Health Quality Partners that does state level adult clinical guidelines that I think, when I compare those at least to the task force recommendations, are a lot more favorable to giving doctors enough latitude to be able to engage in risk-based prostate cancer early detection in a way that doesn't make them feel like they're doing harm to their patients. And I'd like to make sure that the physicians on the call know about MHQP and maybe think about doing a little bit of research about what those guidelines say. But we're interested in talking to doctors about ways that they can feel better about screening men, again, in that baseline window between 40 and 50, and setting on an individual basis what their screening intervals ought to be going forward. And based on family history or other parameters, what is the step? What's the trigger to then refer them on to a urologist at that point? I think that can easily be adjusted on an individual patient basis so that, again, we can use the same tools, but we can use them better, we can use them more strategically, and we can do a whole lot better by men in terms of making sure that we're monitoring the high-risk men more closely and that we're monitoring less closely, because the numbers say that makes sense. Okay, so I'm gonna stop there. Okay,
No, that's fine.
and
Thank you, Mark. I mean,
open
I
it up
think,
to either any comments from my physician colleagues or anybody else that
yeah,
would like to
we're gonna, Christine, can you help us allow the folks on the Zoom or Facebook live? Can you help us give them instructions on how they can present their questions, if they should have some, to the physicians here?
Yes, everyone, people have been saying hello to us in the comment section on Facebook Live. So if anybody just wants to throw in a question, I will direct it at the panelists. So just engage us in the comment section on Facebook and I'll direct them over. Or if you'd rather not do it in this setting, you can certainly get in touch with us at the office. But right now, if you want to put in a comment, I will direct it towards our panelists.
Great. And then while we wait for that, there's so many key terms that were mentioned today. Cultural competency, having physicians of color in places of influence, this idea about precision, prevention. I love this idea about our fair share of life. I love that idea, and this baseline testing. And so for anyone on the panel, the first question I would be is, how would you describe, or how would you go about describing the PSA numbers? That we were talking about the PSA numbers. What do they mean, and what does that mean to a patient when they're going to a physician's office? Anyone?
I think I'll take a stab at that. So the numbers are really that are listed as within normal limits go from less than 1 up to 4. Historically, we had used 4 as the cutoff. Fortunately, over the years, as we've gotten more information and better skills around prostate cancer, we're now really honing on those people who are actually rising above 1.0. And if you rise above 1.0, then you probably need to actually have a PSA test checked a little bit sooner to make sure that you're not escalating. If you stabilize and you're 1.5 or less than 3, and you haven't really escalated, and you don't have any abnormalities on exam, then you're probably in an okay zone. Although it's really about a rapid rise, and whether or not you start your baseline, as Mark had said, above 1. Starting a baseline above 1 for somebody who's 40 or even 50 already put you at increased risk.
Thank you. So know your numbers, and 4 being at the top, and 1 being at the warning level, the starting line, the scratch line, so to speak. Second question, stigma. There's a lot of stigma around the digital rectal exam, And Mark, you had hit on this, the things that make a man, so to speak. And how do we address men kind of getting over themselves and getting to a point where they're engaging with their physicians and learning more about their prostates and ways to protect themselves? Any ideas on that?
Well, I don't know if you were directing that question to me, but I'm certainly happy to take a first stab at it. I don't know that there's a quote unquote magic answer to getting a guy to feel good or even willing to sign up for this thing that we refer to as a digital rectal exam. But one of the things, of course, goes back to, again, what does it mean to take care of my prostate, right? And why are you doing the exam? I know that a number of men, in fact, let me set a little context before I make this statement. I spent 13 years at the Dana-Farber Cancer Institute. Myself, and I now know that the gentleman whose name I'm about to mention is a colleague of Dr. Fish, Dr. Jacques Carter. He and I ran a mobile program that educated and screened men for prostate cancer around not only the city of Boston, but greater New England. So in that context, I spoke with a lot of men who had come to the van that told me they wouldn't get a digital rectal exam because the doctor never told them what it was and why they were doing it. They just tell them to bend over, right? And once Dr. Carter and I basically gave them the education that we think they need and deserve, well, okay, that makes sense to me. I now understand why you're doing it, and I understand the benefits to me. So that makes sense. So information is the first piece of this. The second piece of this, of course, is we know. And I don't know how many women are out there on the audience, but we know that men are notorious for not wanting to go to the doctor to begin with. Okay, so at the end of the day, the women in our lives, these are the original influencers. We talk about social media influencers and things of that nature. The original concept of an influencer is all about the lady in your life, right? Trust me, I see I see my colleagues doing this. The women in your life will basically tell you what you're going to do and then what they're not going to do if you don't. Okay, if I could be colloquial. So again, I think that giving men information and understanding the people in their lives, the people in their circle that influence them, I think are key. And it's not just the women. I think it's mostly women. But guys talk amongst themselves, whether at the barbershop or whatever have you, and someone that's had a bad experience is likely to not only share the bad experience, but to position it in a way that makes it sound bad. I think we have an opportunity to change the game, to change the framing. And this is why I'm saying we need different messaging that's public facing. We need men to understand that there are better experiences that they can have. And there are certainly better outcomes that they can have if they're only willing to actually engage in these experiences. So we found those two things to be at least some of the key, because a lot of guys, like I said, got on that van saying, I'm not here to get screened. I'm just here because my buddy's getting screened, or there's no way I'm going to get screened. Almost to the person over 10 years, they all ended up getting screening and thanking us after the fact because the experience was just different than what they were accustomed to.
Thank you, Mark. And Dr. Andre, I think that the mobile screening is something we should probably look into for New Bedford. I think that's a great idea. And maybe as things open up and the spring gets closer to us, that's something we could consider. We have a question from one of the viewers. What role does disparity in health coverage play in inequities in prostate cancer outcomes?
I can speak to that one. So that is a really astute observation, and it's a complex answer because that impact happens at multiple levels. Take two men, doesn't matter if they're white, black, Latinx, or anything, just take two men who are the same age and have the same prostate condition, which has been undiagnosed. Okay, undiagnosed. One has health insurance. The other one does not. Which one do you think is going to book an appointment with their doctor? All right. Which one, having booked an appointment with their doctor, is actually going to get the kind of checkup that they need? All right. So that's the first level. And in this country where healthcare is not a right, it is not a guaranteed, it is linked to employment, it is linked to unemployment. We have problems in this country. Every other industrialized nation in the world's got the memo. It's a right. Everyone gets to have medical care, but we have a problem in this country. Moving beyond that, okay, talk about getting up to the towing the line. Moving beyond that, let's assume now that despite whatever, the guy who doesn't have insurance has listened to the woman in his life who's told him what he's going to get and what he's not going to get, and he goes and having his exam, right? So now you got the guy with insurance and the guy without insurance, both same age, same undiagnosed prostate condition, both getting their exam done. Maybe both getting a digital rectal exam, maybe both getting a PSA. Here's an interesting little wrinkle, which is why I think that what Dr. Caldas was saying about needing the right kinds of tools to advance the conversation beyond the PSA is spot on. We don't have the right kinds of tools yet, but they're actually available. Some are available. They're not very good, but some are available even after the PSA. If a guy gets a PSA of, let's call it 1.5, or maybe call it 3.5, which is right on the borderline of, maybe we need to look into this some more. The guy who has insurance, the doctor's conversation with him is going to be, well, Joe, it's 3.5. It isn't definitely prostate cancer, but we should probably go on to a biopsy, but maybe there's this other test that we can do. It isn't necessarily picked up by insurance. Maybe your insurance does, maybe your insurance doesn't. It's about $3,000 or $4,000. Do you want it or not? And Joe says, well, doc, this sounds pretty serious. I'll check with my insurance, but yeah, let me go ahead and have it. Now, the same doctor, all right, turning to his patient who doesn't have insurance, do you think he has that conversation with him, with Frank, saying, Frank, it's 3.5, not really sure, what we should do with this. There are some new tests we could look into, but it's 3,500. Do you think that the doctor is going to have that same conversation? This is where unconscious bias comes into the practice of medicine. And, respectfully for all the doctors who are on the call here, we're no different than anybody else, whether you're lawyers or doctors or anything else. Unconscious bias seeps in. We're looking at the sheet and we know this guy's got no insurance. We don't want to embarrass him. And so what do you think happens? It's probably not the same conversation. It's more like, well, why don't you come back next year and we'll see where we are, right? As opposed to having this additional test made available. So this bias does happen all the time. I am intimately involved with new and emerging prostate cancer tests. I can tell you that their adoption rate is very poor, but they are being used by some doctors for some men and not for others. And this is where, again, the insurance game, as it is in our country, and coverage has an unwanted effect on the treatment of men in terms of their diagnosis, and they're going on to get further treatment.
You mind if can I amplify that a little bit, Damone, if I may?
Sure. Yep.
I want to build on those excellent spot-on comments that Dr. Fish just made by introducing another scenario, because he talked about an insured man versus an uninsured man. We also know that there are disparities between insured men and underinsured men, right? So when you talk about income levels, when you talk about places of employment, if you're talking about Mass Health versus Blue Cross and Blue Shield or whatever have you, doctors are going to have the same conversation that Dr. Fish talked about, differently for a man who's insured at this level as versus a man that's insured at some other level. Also, if you talk about inequities in terms of prostate cancer outcomes, it even begins further downstream than that. Because when you think about chronic conditions, think about, obesity or other things that might exacerbate the bad outcomes from cancer, or B, which is my other point, may be issues if men, again, think about the fact that we're talking about high risk men, possibly being diagnosed with advanced stage disease, possibly having gone through treatment that may or may not have worked. And maybe there's time or an opportunity for a doctor to talk with a patient about a clinical trial. We know that most doctors don't really bother to talk to Black men about cancer clinical trials because they don't think that they're eligible, or they don't think that they'll continue their adherence to those protocols, right? A lot of times, maybe these men aren't eligible because of that underlying condition. And that gets into a whole different conversation about the inequities that lead to those underlying conditions. So I want people to think about this as a continuum. Think about this as a process, right? So that if the bad outcomes start early, they tend to build on themselves to the point where by the time you're looking at progressively more serious conditions, then you're looking at, again, whether it's poor outcomes, whether it's issues around getting certain kind of treatments that you may or may not need, or that you may need and not be able to get. And Dr. Fisher talked about those unconscious biases. A doctor may just look at patient A and say, well, I'm not going to talk to that patient about a clinical trial because they probably won't be able to get off time from work to do it. They won't adhere to the protocols. They'll make decisions for a patient before they actually share the information. I know a lot of doctors in the Boston area that are specifically looking at, from a hospital to hospital, institution basis, examining treatment disparities, particularly for prostate cancer. And we're beginning to understand that certain hospitals behave in certain ways. And because those hospitals may be in the urban areas where they get to treat more people of color, we're now beginning to see why certain levels of mortality may be associated with certain particular institutions, which may be associated to other policy and operational issues. But none of these things are mutually exclusive.
Thank you, Mark. We're just about at the end of our conference here, and I truly appreciate all the comments, insight, and information that's been shared. I'll start with Dr. Andrade. Any last comments, Dr. Andrade, to the audience or to any of the panelists here?
The only thing I'd like to say is I think, this is something that the more we talk about it, the more people will be comfortable, men will be comfortable going and getting the attention that they need. And it really needs to be destigmatized and demystified and become part of a regular conversation. So the more these kind of programs happen, I think the better the conversations will happen and the easier it will be to have those conversations.
We have a whole week next year. We got a whole week to work on it. Dr. Carlos, last words, last comments?
I agree with Dr. Andrade, and I think that we've done nationally a good job with breast cancer awareness. Prostate cancer is really several steps behind that, and we need to take the same approach and as far as getting the word out and making it kind of a natural thing to do, as we've done with mammogram screening.
Got it. Mark, last words?
Yeah, and I'll be brief this time, and I apologize for space earlier. But I want to highlight, Damon, the fact that you mentioned the work of the Pink and Black Education and Support Network.
Yep.
And purposefully talked about the role of women as answers in men's health, so that I could just mention to folks, Black is wonderful organization. History dates back to 2005 when it used to be the Pink and Black Ambassadors. And even then, that group was forward thinking enough to understand that the same way that we message women about breast cancer, so we should be messaging to men about prostate cancer. We should be supporting one another, men supporting their women in their lives that are dealing with breast cancer, and vice versa, women supporting the men in their lives that are dealing with prostate cancer. I say all that to say, conversations about prostate cancer, to Dr. Andrade and to Dr. Caldis's point, isn't just conversations that we have to have with men. We have to have them with women too. Because I think Dr. Fish mentioned it earlier. This doesn't just impact men, it impacts everybody. It impacts the whole family. It impacts the extended family. It impacts friends. So this is a very broad conversation. The more that we talk across gender lines, and the more that we talk about prostate before we get to the point where we're talking about prostate cancer, I think the better off we'll be in the long run.
Thank you, Mark. And so as soon as we get our MB Alive group together, we will come together and meet with Pink and Black. So I promise you that. Dr. Fish, last words, comments?
Thank you, Damone. We have this saying amongst ourselves now that we live in remarkable times. And while it feels true, I'd like to point out that in the history of this planet, for Homo sapiens, most of the history has been about war, pestilence, and plague. Whether it's cholera, tuberculosis, this planet and Homo sapiens have had countless episodes of plagues and pestilence. So this COVID-19 is our generation's experience of that. Why do I bring that up now? Well, we have to remember that what's different about our generation is that we have the scientific basis to understand these things. We have reasoning skills that allow us to understand how to keep ourselves safe. It's about wearing masks. It's about social distancing. It's about not making exceptions and excuses. I'd love to see my son, who's in Germany right now for Thanksgiving, to have him come and visit with us. But he must not risk that. He's too important. And I don't want him bringing it to me and my wife. And this Thanksgiving will suck. But you know what? In the history of the planet, we're better off than most generations. But what we can't let this plague do to us is prevent us from getting the care that we do need. We do need to go see the doctor. We do need to get our checkups. We can't let this be one more excuse on top of every other excuse that we as men like to have for not going and seeing the doctor and getting done what needs to get done. So we do live in kind of remarkable times, but not that remarkable. Get the job done. Go get your prostate cancer risk test.
Man, I could do this for another hour. This is we have to do this again, another venue and another situation. I got to get you guys back together again. So in closing, we encourage all men to take their healthcare providers, to talk to the healthcare providers about their individual risks of prostate cancer in order to make joint and shared decisions on screening, diagnosis, and treatment. This week, let us thank our medical professionals, community partners, and local advocates who work diligently to raise awareness about prostate cancer and renew our commitment to make cure available for every man once and for all. So I want to thank the panelists here for everything that you've done for us, for the time that you spent with us, the information that you shared. I want to thank AdMeTech for their support, and Christina, my assistant, for her support, and everyone else who joined in with us tonight. Thank you, and we'll see you guys again. Have a great night and happy Thanksgiving.
Thank you.